may miss, not because we're better than them or smarter than them, but it's really because we have that advantage of being able to interview and talk to the patient. So how do we know when do we even need to order neuroimaging? When is that appropriate or necessary to do? And it's really important when red flags are present. And we'll talk about what some of those are in just a moment. Also, if there are any signs or symptoms that localize to the optic nerve, the optic chiasm, the retrochiasmal visual pathways, the brainstem, or the orbit. So areas that we can localize with neuroimaging. And then also we'd want to have a reasonable expectation that we would find something that would change how we care for the patient. So if it wouldn't make a difference in the patient's care, then we need to rethink, do we really need to order this neuroimaging study? So these are some guidelines of how and when it's appropriate to order neuroimaging. So I talked a little bit about neuro-ophthalmic red flag, and these would be a reason for imaging. So let's go over what some of those would be. A new visual field defect can sometimes be an indication for neuroimaging. An unexplained relative afferent pupillary defect, optic disc edema. And I would remind you too is not all of these findings would always need neuroimaging, but these are the kinds of cases that you would want to consider it in. Unexplained optic atrophy, especially when looking for a compressive lesion as a cause. Painful vision loss that doesn't have an obvious ophthalmic cause. Diplopia with neurologic signs or unexplained diplopia. Horner syndrome signs, so especially when there's unilateral miosis and ptosis. And so that's what is shown here in these photographs. And cranial neuropathies, as well as, of course, progressive symptoms. It's worth mentioning as well, there are risks of overimaging. It might seem simple to, well, if we don't know what's going on, let's just image everyone. Let's just get everyone an MRI of the brain or MRI of the orbits, and that should solve our problems, right? Well, not exactly. There's a big risk of finding incidental findings. And incidental findings are findings that are present, but maybe have nothing to do with the clinical presentation and may not even be a sign of disease or of any abnormality that needs to be further pursued. However, many incidental findings end up leading to further testing and investigation, and sometimes even interventions that can be unnecessary and actually bring harm to the patient. And it's a significant risk of iatrogenesis. So we can actually harm the patient sometimes by frivolously ordering neuroimaging when it's not indicated. It's also burdensome to our patient and to the healthcare system. It's costly. It ends up consuming resources that can be used for other things. Some examples of some things that may be incidental findings that sometimes get over-evaluated might be a mild asymptomatic Chiari malformation, a pineal cyst, which is actually what we see in this MRI image here on the right. See the arrow pointing to this cystic structure. So that's a pineal cyst, which is often benign. Arachnoid cysts are often benign as well. And then a lot of times meningiomas, especially if they're small and not pressing on anything important involving the skull base or the brain, those can be examples as well of an incidental finding that doesn't need further evaluation. There was a study called the Rotterdam Scan Study, which looked at the incidence of incidental findings, and they found that 9.5% of patients who had a scan in this study had an incidental finding of some kind. And 3.2% were referred to a specialist, and 76.6% of those who were referred to the specialist were observed or discharged from the clinic. In other words, the specialist didn't really need to do anything in those cases. So we're finding, again, a lot of kind of healthcare overutilization in some of these cases, again, with respect to overimaging. So we want to make sure that we order just when it's appropriate to do so. And on the flip side, there's also risks of underimaging. So we can miss a vision or a life-threatening condition. We might have false reassurance from a normal study or a study that's read as normal when it really isn't. For example, a head CT has about 16% sensitivity for posterior fossa infarcts. So it's infarcts of the brainstem and the cerebellum. Only 16% of those will be detected on a CT scan. So it can be falsely reassuring to think, oh, I got a CT scan and it's normal, therefore everything's fine. So in summary, there, both over and underutilization of neuroimaging can be harmful. So today I'd like us to consider when is it appropriate to to pursue neuroimaging, and how do we interpret those results? So here are some situations where neuroimaging may be low yield. So one is with typical migraine aura. So if it really sounds like a migraine aura with jagged edges, colorful scintillating scotoma, and this kind of arcuate pattern, and it grows or shrinks over time, that's a typical migraine aura, and that's something that probably does not need neuroimaging in most cases. Also, long-standing stable congenital findings, those may not be necessary, and improving classic microvascular cranial nerve palsy, and anything that's clearly an ocular pathology that explains the symptoms. In a lot of those cases, we really don't need neuroimaging. So now that we have that out of the way, let's say we find that it's appropriate to order neuroimaging for a patient. How do we know what study we should order? So we're going to focus just mostly on MRI and CT scan here. I realize there are other neuroimaging modalities, but we're going to focus on these two as some of the most helpful for the diseases that we see. So an MRI is best for looking at soft tissues, and CT scans are really best for bones and blood. So so soft tissues that would be helpful to evaluate with an MRI would include the optic nerve, optic chiasm, the brainstem, looking for any demyelination in the central nervous system, and for tumor characterization. Those are soft tissue issues. And so those are MRIs going to be best. CT scans are best for trauma, acute hemorrhage, looking for fractures of bones. Emergency imaging, CT scans are usually easier and cheaper and faster to get, and it can also look for calcification well. And then, of course, the study, we need to decide, does it need contrast or not contrast? And things that help us decide that, you often do need contrast if you're suspecting a possible neoplastic or inflammatory condition or demyelination, if there's a possibility of meningeal disease, or if you're getting an MRA or CTA, which is looking at blood vessels. Contrast is usually helpful in those cases. Without contrast is perfectly acceptable when there's a likely acute ischemic stroke, or there's a low likelihood of any pathology really, and you're doing the scan to rule out some serious things that are not super likely. And if there's a contrast allergy or contraindication in some other way to contrast. So I'm not going to bore us too much here, but we do need to understand just some very basic things about MRI, I think, before we get into some more details. So an MRI, the principle here is that the body is placed in a strong magnetic field. And that strong magnetic field ends up aligning the hydrogen protons that are abundant in water and fat. And so they'll look kind of like this, where they're all oriented within that magnetic field. And then a radio frequency pulse is applied, and that tips these protons out of alignment. And then after that pulse, the protons relax back to their original state. And different tissues have different relaxation times, and the MRI coil is able to examine that, and it can give contrast to T1 weighted images. And by contrast, I don't mean intravenous contrast. I mean the contrast where one tissue will look different from another in terms of its signal intensity. And the reason this is important and why we're going over this here is because every sequence on the MRI, there are different sequences, they measure a different tissue property. And so we need to think about that based on what diseases we're looking for, and we can see what sequences might be appropriate to look for those specific properties. And so those are based on different properties of the soft tissues. Now a few words about contrast. So CT scans use iodinated contrast, so it's an iodine-based contrast. And patients can have allergic reactions. They can also have contrast-induced nephropathy, where there's some kidney dysfunction that's induced by the contrast. MRI uses gadolinium or forms of gadolinium. And allergic reactions, fortunately, are less common with the gadolinium-based contrast media. And some types of gadolinium, not all, there are some newer ones that don't, but some types are associated with something called nephrogenic systemic fibrosis in patients with severe renal impairment, which can be a really devastating disease that causes significant fibrosis. Normally, contrast is separated from the brain and the nerves by the blood-brain barrier, and that's why we have an illustration here on the right. And the blood-brain barrier lines the blood vessels, and it keeps the contrast in the vessels. So when contrast leaks out, it tells us that there's an impairment of the blood-brain barrier. And that happens with tumors, with infections, with inflammation. Those all disrupt the blood-brain barrier. So when you think of a case where there's an imaging study with contrast, an MRI, and there's a leakage of contrast, there's abnormal contrast enhancement, think about these kinds of processes, tumors, infections, and inflammation especially. Now let's understand a few MRI sequences before we apply these to some actual cases. So some of the sequences we're going to go over will include T1 pre and post-contrast images, something called FLAIR, which is a T2-based sequence, DWI and ADC, and we'll explain what those are here in a moment. Another one called STIR, another one called T1 fat suppression, which actually subtracts fat so you can have a better view. And then all of these sequences, or most of these sequences, are available in different views. So there's axial views, which is a slice through the head this way, coronal, which is a slice through this way, and then sagittal, which is a slice through this way. So let's look first at T1 pre and post contrast, and what do we use those for? So the T1 images measure how quickly protons realign with the magnetic field after excitation, and different tissues have a different relaxation time, and that gives the different signal intensities. And so this tends to be really good for looking and also for post-contrast enhancements. We can see are there areas where the blood-brain barrier is dysfunctional. On T1 weighted images, fat is bright and fluid is dark, which is the opposite of T2 weighted images. So fluid is dark here. So for example, fluid within the ventricles will be dark. Fluid in the cisterns around the brainstem, that'll be dark. And then here, this is a post-contrast image, and you might think, well, there's a lot of fat in the orbit. Why isn't that bright? And that's because there was fat suppression here, which we'll go over here in a little bit. But what I'm pointing out here with the arrows is there's some bright signal here on the post-contrast image, and this is the prechiasmatic left optic nerve right here. And you see that there's a little bit of brightness there that's not there on the other side. And that's a clue that there's some abnormal contrast there. And that tells us, again, we want to suspect things like inflammation or tumor or infection. And here we are in a coronal view, and same thing, we see some brightness of the prechiasmatic left optic nerve, and we do not see brightness of the right prechiasmatic optic nerve. This was a case of optic neuritis that was acute. And a T2 FLAIR-based sequence, you can think of as basically like a T2 sequence minus the CSF. So it's like the CSF has been subtracted for you. And the FLAIR stands for Fluid Attenuated Inversion Recovery. And it's a T2-based sequence, again, that nulls the signal from free-flowing CSF. Myelin and fat are dark in this sequence. And it's great for looking for edema, inflammation, or gliosis, which is scarring. And so one thing you'll notice here is the cortex, which is gray matter. Notice how it's brighter than the subcortical structures, which are highly myelinated. And remember, myelin and fat are dark, and so that's why that area of the skin is darker. And then what we're pointing out here with the arrows is an area where it's excessively bright. And in this case, that's because of edema. So there's increased fluid here, and fluid is bright on a T2 FLAIR-based sequence. So we can see there's something edematous here in the right occipital region. And this was a patient who had an acute ischemic stroke in the right posterior cerebral artery territory, and that led to this finding. Fat saturation, there's a few different ways to look at that. One is with a STIR sequence, which stands for short tau inversion recovery. It's like a T2-based sequence minus the fat. And so it's really great for looking in the orbits. And so here's an example of a coronal T2 STIR. And one of the pearls to know about the optic nerve here is that the optic nerve has lots of myelin in it. So it's got a lot of fat. And that fat really should be about the same as the myelin in the frontal lobe up here. So see how dark that is and see how dark it is here in the optic nerve? That darkness is about the same, and that's normal. Now notice if you look at the left optic nerve, notice that it's a bit brighter there. It's not as dark as the frontal white matter, and it's not as dark as the other side. Those are signs that there's increased T2 signal within that optic nerve. You can have that from edema. You could have it from optic neuritis. You could even have it from prior damage to the optic nerve that's not active at all. Those things can all cause brightness of the nerve. And again, this is not contrast enhancement. This is T2 hyperintensity. So this is a great sequence for looking in the orbits because it subtracts out the orbital fat and allows you to really get a good view of the optic nerve. Now, T1 with fat suppression is a T1-based sequence, and it's also known as fat saturation. And here we are with the T1 sequence without fat saturation. Notice how bright the fat is in the eye socket. You can imagine how that would be a problem if you're looking for bright signal in the optic nerve as well. And so one way to get around that on the T1 post-contrast images, right here you see that the fat has been subtracted away. That's not bright anymore. This bright signal here is of the lateral rectus, and here's the medial rectus muscle, and those normally enhance. And then here we can see the optic nerve without being distracted by the fat, and we can see that, oh yeah, this is that image we saw earlier where the left prechiasmatic optic nerve is a bit inflamed. And this is great for looking for abnormal enhancement within the eye socket. So that fat saturation is usually a feature of MRI orbits protocols, and so you should get that. DWI and ADC are helpful for looking for acute ischemic stroke. It stands for diffusion-weighted imaging and apparent diffusion coefficient. I won't go over exactly what those mean, but just know that these measure the random motion of water molecules. And when there's normal random motion of water molecules, the signal is dark. And when it's restricted, as in with acute ischemic stroke, you get brightness there. And that's what you see here with this stroke in the right occipital lobe. And that is from cytotoxic edema that restricts that diffusion of water. And then on an ADC image, that should be dark in acute ischemic stroke, and the DWI portion should be bright. So if you see that DW bright, ADC dark, you know that is acute ischemic stroke. And then I alluded to earlier that there are different ways to look at each of the sequences in different planes. So it could be axial, coronal, sagittal views. So here's a coronal view, which can be great for looking at the optic nerves. And then here's a sagittal view, which shows that infarct that we were talking about earlier in the occipital lobe. And so you can really do that with any sequence. And it sometimes helps to view an abnormality from multiple perspectives to really characterize it well. And you can see, for example, if a mass is contacting the visual pathways or look for other details. So there are some common ordering mistakes that you want to be aware of when you're ordering a scan. So you want to make sure that you don't scan the wrong area. Another mistake is not giving the radiologist enough information. And again, even when you're ordering, you want to think like a neurologist or a neuro-ophthalmologist. You want to localize first, then decide what scan and protocol you need. And if you're not sure, you can always call the radiologist and ask them. And you want to describe the suspected localization in your requisition for the radiologist. So here's an example of a radiology requisition. So let's say you're concerned about optic neuritis potentially, and you order an MRI of the orbits with and without contrast. And let's say you know that you want to see a stir sequence, a coronal stir sequence. You can say that. You can actually specify if there's certain sequences you think you need. You can let them know that. And then reason for exam, that's where I put the localization and any relevant clinical symptoms. So here, let's say I have a right optic neuropathy, and then that will help the radiologist know that that's where this localizes, and please pay special attention to that area. The question always comes up, or often comes up, about do I need an MRI of the brain or an MRI of the orbits in this particular scenario? And it's helpful to know what some of the differences are between a brain protocol MRI and an orbital protocol MRI. A brain protocol has a larger field of view but lower spatial resolution. The MRI orbits is zoomed in a little bit more and has a higher spatial resolution. Also, the slice thickness is thicker with a brain MRI than it is with an MRI of the orbits, which has thinner slices. The MRI orbits also has fat-saturated sequences. There's often coronal plane imaging in the orbit scans as well. Brain may or may not include that. And then there's lots of other sequences in the brain MRI. There's fewer sequences in the orbits because we're usually not looking for acute ischemic stroke and things like that there. So to summarize that briefly, MRI orbits usually has higher resolution, has fat suppression, and has thinner slices. And that can be useful in certain situations. CT angiogram and MR angiogram and MR venogram are additional studies that we can order that look at blood vessels, can help us find and identify vascular pathologies. So aneurysms can also help us identify if a aneurysm is compressing the third nerve and causing a palsy. That's a common indication for us to get neuroimaging with the vessels. Horner syndrome, stroke or TIA, those all make it necessary to look at blood vessels. And of course, venous sinus thrombosis, looking at the veins. So if I were to assemble kind of a cheat sheet for you, to figure out, okay, well, for certain clinical problems, what kind of imaging should I get for those? And this may be a helpful reference for you. So optic neuritis, MRI brain in orbits with contrast is going to be helpful. Chiasmal syndromes, MRI of the sella or pituitary. Third nerve palsy, MRI brain, and then we also need vascular imaging of a CTA or an MRA of the head to exclude aneurysm. Papilledema, you at least need the brain and may also need the orbits. Sometimes an MRV of the head can be helpful if venous sinus thrombosis is on the differential diagnosis. MRI of the brain is the test of choice for homonymous hemianopia. And then for orbital disease, an MRI or a CT of the orbits, depending on what you're looking for, can serve your purpose as well. Now, how do we read the scan? So a reading strategy here may be to first confirm the correct study and the correct patient. There's been times when I've looked at a study and start, reviewing it and realize, oh, whoops, this is the wrong patient. So do make sure you have the right patient and study. And then always think, based on my history and my examination of this patient, what am I looking for? And more importantly, where? Where is the problem going to be or likely to be? And then select the sequences to review that you want to review, and then focus on the area that you've localized, or if you don't have a specific localization, you may just try looking through the visual pathways generally. For anything that you're evaluating, whether there's bilateral structures, always look for symmetry with the normal side. So that applies to, for example, the optic nerves or the optic tract or the occipital lobe. Those are all paired structures. So if you have an abnormality on one side, potentially, you want to look at the other side for symmetry. And then, of course, read the radiology report and see what they have to say. I think it would be helpful for you to accept a challenge here for me today, and that is for you to on your own time review some neuroimaging studies and try to trace the visual pathways through the study on your own. And the goal there is to practice identifying things like the optic nerves, the optic chiasm, the tracts, the occipital lobes, and then try doing that in different views, axial, coronal, and sagittal. If you're able to do that on some normal patients, that's going to greatly increase your ability to do that more effectively when you have an abnormal patient. And all these different visual field pathways have different manifestations in terms of the visual field abnormalities. And so that's one of the keys to localization with visual fields. And so here's an example of someone kind of tracing the visual pathways on an MRI. There are some common imaging pitfalls to be aware of and to try to avoid. One is missing subtle enhancement. So subtle abnormal contrast enhancement can sometimes be missed. So you can minimize that by knowing exactly where to look and what kind of diseases you're looking for. Motion artifact can be a challenge and can blur the image and making it harder to see relevant abnormalities. Don't always assume that a normal report equals a normal scan. Again, because we can interview and examine the patient and localize, we can sometimes find things that radiologists might not know about. And along those same lines, blindly trusting the radiology read can sometimes not be the right approach, especially if we have additional information that was not available to the radiologist. And then, of course, ordering the wrong protocol. So if we order the wrong protocol, we're limiting our ability to really evaluate the structures in question. And of course, incidental findings. Incidental findings can really be a problem, so we want to make sure that we're not over-imaging. We just want to use imaging when it's appropriate. All right, now let's try to apply these principles that we've just learned to some actual cases. So these are real cases that I've seen. This is a 28-year-old woman who presents with decreased vision in both eyes. She has pain with eye movements that started 2 weeks ago. And then 4 days after that, she noticed decreased vision in both eyes with sensitivity to light and difficulty seeing colors. So I want you to pay attention here because we're going to ask a question of the audience of where does this localize? So as we're presenting the case, think about where is this problem coming from? The vision continued to decline in both eyes over days, and an MRI of the brain and orbits with contrast was read as normal by the radiologist. The patient saw an optometrist who found hazy optic disc margins and diagnosed non-organic vision loss. On examination, there's decreased visual acuity in the right eye more than the left eye that's pretty severe. And the patient had very diminished color vision, had no relative afferent pupillary defect, but did have sluggish pupillary reactions in both eyes, and was able to count fingers in all quadrants, and had some mild disc edema in each eye on examination. So again, we want to think about where does this localize? So here are the visual field test results. So we see some generalized depression here in the left eye, and in the right eye, there's central depression that extends into the mid-periphery as well. And then on OCT, we do see some evidence of optic disc edema that's fairly mild in both eyes. All right, so let's get ready to respond here. So where do you think this patient's vision problem localizes? So is this bilateral retina, bilateral optic nerves, bilateral optic tracts, bilateral occipital lobes, or bilateral visual association cortex? So that pulls there, and we'll leave that up for a little bit and allow everyone to answer. Okay, and most respondents responded bilateral optic nerves, which is the correct answer. So that's going to really focus when we're ordering the neuroimaging and looking at it. We're going to want to focus on that area, on that location. So let's do that. So here is the MRI. So here's T1 axial post-contrast images on the top left, and the bottom left is post-contrast in the axial, or excuse me, in the coronal plane. And it's kind of subtle here, but there is some bright signal of the optic nerve, and right here and here. And what it should normally look like is it should look like the brain here, which is kind of dark and just there's no contrast in there at all. Here, this kind of lights up a little bit, even though it's subtle. It's there. And this was actually missed by the radiologist. And part of it was probably because it was bilateral. Each side looked the same. But with our clinical history, we recognize, hey, this is optic neuritis. There should be an optic nerve abnormality there. And it seems to be in both eyes. The T2 coronal images show increased T2 signal of the optic nerve, which again can be a sign of edema or of prior damage. Since there was no history of prior damage, this was probably edema, which fits with acute optic neuritis. And here's what a normal optic nerve looks like. Notice how dark it is. Same darkness as this frontal white matter. Here it's clearly brighter than the frontal white matter. So you know that that's abnormal. And unfortunately, she was undiagnosed with non-organic vision loss, and we diagnosed her with optic neuritis. We treated her appropriately, and her vision got tremendously better. She was left with a little bit of optic atrophy, but did well overall. And she was grateful that we were able to localize and review the images ourselves. All right, let's move on to case number 2. We have a 62-year-old man with decreased left eye vision. And he noticed decreased left eye vision 3 years ago. And he had some optic disc edema at that time in the left eye. An MRI of the brain with contrast was read as showing posterior left optic nerve thickening consistent with optic neuritis, was the way it was read. And on examination, there was a little bit of decreased visual acuity in the left eye, very slightly decreased color vision. There's a left relative afferent pupillary defect, and there's some severe generalized constriction on visual field testing with some mild optic disc edema in the left eye. Now, again, we're thinking like a neuro-ophthalmologist, and we want to localize the problem first. And this one's obvious. This is another left optic nerve problem. But then we want to think about, okay, well, what could this be? And does this fit? Left optic neuritis, would that be going on for 3 years with optic disc edema over 3 years? No, it wouldn't. And so we already have a reason to suspect that the radiologist read might not be entirely accurate there. And again, this is because we can take a history and exam from the patient. And so we get this T1 coronal post-contrast image, and it shows this enlarged optic nerve sheath complex here that's bright. This is contrast enhancing. And here's the coronal image, which shows some brightness in that area as well on the T2 weighted sequence. So again, things like edema can do that. And then here on the T1 axial, we see this area. It's very well demarcated. And now we're thinking about, okay, this doesn't fit clinically with optic neuritis. So what else could this be? What would be there for 3 years and cause a little bit of disc edema and have this focal area of enlargement that's been there for a few years as well? And then as we think about that, well, that could be an optic nerve sheath meningioma. And that's actually what this was. This was a nerve sheath meningioma, and that's going to be treated differently than optic neuritis. So it was really helpful that we could get the right diagnosis and help that patient. And part of this was because we could review the images on our own, and we were armed again with our localization, with our history and our examination. Now, case number 3, we have a 70-year-old woman with bitemporal visual field loss. And this vision loss started 6 months ago, and an MRI of the brain was done at that time and was read as normal. So the patient was diagnosed with migraine, but the symptoms seemed to have progressed, or at least didn't really go away. So visual field testing showed this. And so here we see a bitemporal hemianopia that's pretty dense. And then on the OCT, I took a snapshot from the ganglion cell analysis, which remember, these are the cell bodies of the axons that are forming the nerve fibers in the optic nerve. And if I draw an imaginary line through the center of the macula, through the fovea, we see that there's nasal thinning in the left eye more than the right eye here. And when we see that pattern, when there's just nasal thinning and you have the temporal visual field defects, that localizes somewhere very, very specific. And you guys may be aware of where that location is. And to not give it away here, I'm just gonna ask us, based on your own thoughts about where that localization is, where does this problem come from? What would be the most appropriate imaging study to order in this case? So the audience response question is up, and please select the most appropriate answer. So would it be a CT of the head, a CT of the orbits, an MRI of the brain, an MRI of the orbits, or an MRI of the sella/pituitary? All right, and most answered MRI of sella and pituitary, and that is correct. That would be the most appropriate because we know that this localizes to the optic chiasm, and the MRI sella and pituitary is going to give us the best images there. An MRI of the brain might get some of the area that we need, but certainly a better protocol is MRI sella and pituitary. So here is a T2 axial flare image of this patient. Remember, this MRI of the brain was read as normal. And one thing we see here that I'll point out is see this circular structure right here that's dark. So it's the same density as the CSF. And here we are some other views. Here's a coronal T2 image. And what I'll point out on the normal image over here, this is a T2 coronal that's normal. Notice the optic chiasm right here. Look at its shape. And then notice this one. This optic chiasm doesn't have the same shape, does it? It's bowed upward. And it's bowed upward in the same region where this circle is. And you see this circle here that is bright, and it's the same density as the CSF. So there's something there, and it's actually pressing on the chiasm. And here's another view, T2 coronal flare. And again, you see the same dark circular thing that seems to be deforming the optic chiasm. So you can imagine how the radiologist could miss this because it looks the same as the CSF. But there's clearly something there, and we know that because we know where this localizes. We know where the problem is expected. And so this patient ended up having a cyst, a pituitary cyst that was compressing the chiasm, and because we were able to read the images independently and know that the MRI was not normal, this patient was able to get surgery, and she had improvement in her vision afterwards because the surgery took care of the cyst, drained it, and took it out. So great outcome for her, which would not have been possible if we had just trusted the radiology read. So case number 4. Here is an 83-year-old woman with a left homonymous hemianopia. She noticed about 6 months ago that she had some difficulty with her vision. Her husband actually tried testing her visual fields, and he was the one that actually found a left homonymous hemianopia. And an MRI several months after symptom onset was read as showing microvascular changes and no acute abnormalities. And so here was the visual field, and it's not a very subtle homonymous hemianopia. This is a pretty obvious one. And we know where that should localize. We know that homonymous hemianopia is localized to the retrochiasmal visual pathways on one side of the brain, on the contralateral side. So if this is a left homonymous hemianopia, this is a problem in the right retrochiasmal visual pathway. So this could be the optic tract, it could be the optic radiations, it could be the occipital lobe. So it could be any of those locations, but there should be something there. And the MRI of the brain was read as normal. So we need to look at it ourselves and see, do we agree with that? So here is a T2 flare axial image. And as we compare the occipital lobe here on the patient's right, which is the left side of the image, and the patient's left, which is the right side of the image, we notice that there's a difference between the two, right? Remember, paired structures, we want to look for symmetry, and this is not symmetric. This is normal over here on the left. this is not normal here on the right. We see this dark space right here. We also see some bright signal around it. This is encephalomalacia. This is damage to the brain that's happened from something. And in this case, it happened to be an ischemic stroke. And we're catching it months later, so it doesn't have the characteristics of an acute ischemic stroke, but it still has left behind brain damage that is detectable. And again, the MRI brain was read as normal by the radiologist, but we knew where to look. We knew localization, and that helped us look at the images ourselves and realize, hey, no, that is not normal. There's some damage that's there. And now case number 5. So we have a 58-year-old man with a history of hypertension, and he is eating dinner at a restaurant, and his right eyelid started twitching. And around the same time, he noticed an aching pain around his right eye. The next morning, his right eyelid was drooping, and he had some pain radiating to the right cheek and ear. So on examination, we find that he has some anisocoria. And to figure out which pupil is the abnormal pupil, we examined him in the light and in the dark. And in the light, so he's holding his upper lid up here so we can see his eye better. We see that the right pupil is smaller than the left pupil. And then in the dark, the right pupil is also smaller than the left pupil, but the difference is greater in the dark. So that tells us that the smaller pupil is the abnormal pupil. And that would make sense. There's ptosis and meiosis on that side. And I think you guys may be knowing where this is going. Now, after the administration of aproclonidine eye drops, we find that the anisocoria has reversed. Now the right pupil is actually larger than the left pupil. And that happens from denervation supersensitivity. So we know this is an oculosympathetic palsy, which is also known as Horner syndrome. And this results from damage to a very long pathway in the nervous system. And to know how to order neuroimaging for these patients, we do need to understand a little bit about the anatomy. And this oculosympathetic pathway is a 3-neuron chain. And a lesion anywhere along that 3-neuron chain can cause a Horner syndrome. It starts in the hypothalamus, descends through the brainstem and through the cervical spinal cord, exits at about where the cervical spinal cord and thoracic spinal cord meet, and then ascends in the cervical ganglia and the cervical chain, and then synapses in the superior cervical ganglion. That's the second synapse. The first synapse was here in the spinal cord. And then the fibers then climb on the internal carotid artery and eventually make their way into the orbit. So you have this big long pathway, and that is where this localizes. So we don't know where in this big pathway, but we'll need to look at this whole pathway with imaging. So always remember, we have our history and exam, which confirms there's a right Horner syndrome, and the localization is going to be somewhere along that pathway that we just talked about on the right side. And then we're going to figure out what studies to order for this. So now, so an acute painful Horner syndrome should prompt immediate imaging to exclude which of the following: a cavernous sinus thrombosis, a carotid artery dissection, pituitary adenoma, giant cell arteritis, or an orbital mass. All right, most answered a carotid artery dissection, which is correct. So anytime you have a painful Horner syndrome, always think about carotid artery dissection as a can't miss diagnosis. And here is what this patient's dissection looked like. And this is an MRA of the neck. And we see here a hematoma within the blood vessel wall that's partially compressing and occluding the lumen. And that was the source of this patient's stroke. I'm sorry, not a stroke, but this was the Horner syndrome was a result of this dissection. And here is a coronal view, and here is the left internal carotid artery that I'm following with my cursor here. Notice how wide open it is and smooth, and then I'm going to follow the same vessel on the right side, and notice how ratty it is, how thin, kind of irregular, and then it becomes normal right here again. And so that section right here, that's an arterial dissection. And that increases the risk of stroke, and that's why that's important to find. So Horner syndrome imaging, what do we actually order? An MRI of the brain will cover that part from the hypothalamus down through the brainstem, and we'll also cover some of the portions where the pathway then enters the eye socket. An MRA or a CTA of the head and neck is helpful if carotid dissection within the past month is possible. And I say within the past month because 82% of strokes from a dissection, arterial dissection, happen within the first week, and virtually all of them happen within 4 weeks. So if we know that this Horner syndrome has been there for 3 or 4 months, I'm not so worried about dissection because it would have healed by now anyway. And then MRI of the cervical spine with contrast can be really helpful for looking for the parts that go through the cervical cord and that ascend in the neck. So these 3 imaging studies can be really helpful in patients with Horner syndrome to adequately look at the area that was localized. And then one more case here. We have a 24-year-old woman presents with 1 month of headaches and transient dimming of vision in both eyes for seconds when bending over, coughing, or sneezing. She gained 40 pounds in the past 3 months, and she's noticed a whooshing sound in her ears when lying down. She has some papilledema on examination. So she gets an MRI, and she has some MRI findings that are associated with idiopathic intracranial hypertension. The most sensitive and specific radiographic sign for IIH is transverse sinus stenosis, which we see here. See this narrowing of the distal transverse sinuses? It's 84% sensitive and 95% specific for IIH in pooled meta-analyses. There are other signs that can be associated with IIH. You can see protrusion of the optic nerve head into the globe. You can see increased CSF around the optic nerve. You can see an empty sella turcica, which is where the pituitary gland should be. And it's got dark signal there because there's CSF there instead of mostly pituitary tissue. Cerebellar tonsillar ectopia, where the cerebellar tonsils, which is this part of the cerebellum, protrudes below the level of the foramen magnum. And that can sometimes be a sign associated with IH. There's posterior scleral flattening, which is the posterior portion of the globe becomes flat. And there are some other signs as well, but these are some of them. However, not everyone with radiographic signs of IIH actually has IIH. And so one thing I want to emphasize here is that there was a study of these signs of IIH, and it seems that radiologists have really caught on to these signs and have been reporting them very frequently. And do we need to be worried about IIH in all of these patients where a radiologist reports one of these radiographic features? And this study was great. It looked at almost 300 patients who had an MRI for any reason, 300 consecutive patients, and a masked neuroradiologist was asked to look for 10 different radiographic signs of intracranial hypertension. And the patients also had fundus photographs to screen for papilledema. Impressively, of these almost 300 patients, about 100 of them had an empty sella. And so an empty sella is not very specific at all for intracranial hypertension. It's very, very, very common. And only 5 of the patients in this study had papilledema. 2 had IIH, 2 had a brain tumor, and 1 had an encephalocele. And they found that if you had more radiographic signs of intracranial hypertension, the more likely you were to have papilledema. But if you had only one radiographic sign of IIH, the risk of having papilledema was very low. It was less than 3%. So again, just having radiographic signs of intracranial hypertension does not automatically mean that you have that condition. Now, I recognize that many of you may be in settings where neuroimaging resources are limited. So what do you do in those cases? Well, one is to reassess the need for the scan. Do you really need an imaging study here? And I would prioritize the clinical exam and the localization, and then try to figure out from there, how important is it that I get a scan in this patient? And you may save neuroimaging for cases that would need it the most, like visual field defects, afferent pupillary defects that don't have another explanation or a known explanation, or abnormal optic disc findings, so there's a definite pathology that's observed. You also may think, do I have access to a different modality? Maybe you have access to X-ray but not MRI, or maybe you have ultrasound capabilities or a CT scan but not MRI. And so think about what modalities you do have, and you can use those. CT is still helpful to exclude large intracranial masses and evaluate for orbital trauma and things like that. So just because you can't get an MRI doesn't mean you can't do important and worthwhile neuroimaging. And then also consider, would observation of the clinical symptoms be a possibility, even if you don't know what the diagnosis is? If someone's clearly not worsening, then and their deficits are mild, then maybe it's okay to observe even without neuroimaging. So those will be things to think about. Also, are the deficits chronic and progressive? If so, then that's reassuring, and maybe we don't need imaging. Here are 10 neuroimaging pearls that I'll just display on the screen real quickly. Many of these we've already gone over, and this just reiterates them and puts them in one slide for you. I'll especially emphasize the 2 and 1, which are localization. So know where to look based on the history and exam, and then always review the images yourself. Don't assume that the radiologist picks up all the abnormalities that are there. So here in conclusion is our what I'm going to call a smarter approach to neuroimaging. And that's, again, focusing on the history and exam, based on the history exam, localizing where the problem is, and then selecting the best imaging study for that localization and that disease process that you may be suspecting. And then, of course, review the images yourself and the report from the radiologist. And with those, you're really well equipped to use neuroimaging to help your patients and to be a partner with your radiologist instead of relying on them completely. So, and always do them in that order. All right, and then I'll entertain any questions now. So to do that, I'm going to pull up the Q&A, and if you have any questions that you'd like to ask, feel free to chime in the Q&A there. So one question that has come up is, how long after brain tumor surgery should papilledema regress? Yeah, that's a great question. If the intracranial pressure is normalized immediately, it depends on how severe the papilledema is. I've seen some really severe cases that take weeks to improve, and then there's others that may be just a few days with more mild edema. So really depends on the severity, but I'd say anywhere from days to weeks, depending on that. And then in case 1, is this MS-related or MOG or NMO spectrum disorder? So this was actually none of those. This was a case of idiopathic optic neuritis that I showed in case 1. So it didn't have a MOG or NMO diagnosis or MS with that. And a question came up of, regarding the pediatric age group, do the same rules apply? In terms of the neuroimaging rules and the framework that we talked about, absolutely. Absolutely. All those same things apply. So comment here about the NHS and the UK advocates for imaging only atypical optic neuritis, not all cases. Wow, I completely disagree with that. And that is because the MRI of the brain when someone has acute optic neuritis is the best way to look for evidence of multiple sclerosis. And if you miss multiple sclerosis, you're not treating it, and that means that a person is accumulating more permanent disability. And I personally would find that unacceptable. And again, even especially typical optic neuritis will behave that way. It'll be associated with MS in many cases. I've had many cases in my clinic where we've diagnosed optic neuritis. We get the brain scan, and we had no idea they were going to have multiple sclerosis, but they did, and we got them treated right away because of the brain MRI. We would have missed it otherwise. Great question about, when do you image cranial nerve palsies, 3rd, 4th, or 6th nerve palsies? I would say the easy answer to that is just image all of them if you find them acutely. If it's not acute, if it's been there for a long time, I try to assess, is it progressive, static, or improving? If it's improving, you might not need to, if it's very clearly improving, you might not need to image. If it's static or progressive, it still might. In fact, progressive, it's mandatory to image. If it's static or not changing, then you kind of make your own clinical judgment there. But in any acute 3rd, 4th, or 6th nerve palsy, I think it would be appropriate to just image them with an MRI and make sure there's not an aneurysm or a tumor or some other worrisome pathology. What is your standard workup for idiopathic optic neuritis? If it's a typical case of optic neuritis, I just get an MRI of the brain and orbits, and that's to confirm my diagnosis of optic neuritis and to screen for evidence of multiple sclerosis. And that's really all I do for a typical case of optic neuritis. If it's atypical optic neuritis, then I'm ordering things like aquaporin 4 antibodies and anti-MOG antibodies, and may consider additional testing depending on the clinical history and clinical course. Question about how to differentiate hypoplastic venous sinus from thrombosis on the basis of MRV. Yeah, sometimes that can be difficult. Sometimes you can see, is the sinus in question, is Is it uniformly narrow throughout the course? If so, maybe that's more of a hypoplastic issue. Also, if you can get your hands on any prior imaging studies that they've had that might answer that question, that can be helpful. Also see if it seems to be possibly a fully occlusive thrombus, then do they have symptoms associated with that? Do they have papilledema? Do they have headaches? Do they have a venous clotting disorder? Do they have some other reason that makes me think about venous sinus thrombosis? And question here, what is the sensitivity of DWI images in retinoblastoma? That is a great question, and I do not know the answer to that. That might be a great question for a Google search and see if someone has published on that. Suspected retrobulbar hemorrhage, which imaging modality, CT or MRI? So a CT of the orbits will be great for looking for acute blood. So if this is a recent retrobulbar hemorrhage, that can be helpful. And the blood will show up as bright, and so that is maybe the most reasonable study to do there. If it's maybe older blood, or if for some reason a CT scan was done and didn't show it, you might think about MRI and see if that could show it. But again, acute blood, CT is often a good bet for acute blood. So precautions before sending patients for MRI. There's a screening form that patients still need to complete to make sure that they don't have a metallic object in their body, and other criteria to make sure that the MRI is safe for them. That's really the only precautions is that checklist. What are the biggest red flags in a neuro-ophthalmic examination that should prompt urgent imaging? So that was actually one of the slides in the webinar. So I'll have you refer back in the webinar, and that will help. Answer that. Go. And then when are you happy to call it idiopathic optic neuritis? So I'm happy to call it idiopathic optic neuritis if the MRI does not show any signs of another disease like multiple sclerosis or anything else. And if it's a typical case of optic neuritis that behaves the way it should, pain with eye movements, gets better over a period of time, mild to moderate visual impairment from it. So see all the typical, optic neuritis kind of features. And does pediatric optic neuritis need repeat MRI with recurrent optic neuritis episodes? And if it's isolated and idiopathic, can we diagnose clinically and start ONTT? So pediatric optic neuritis, so if a repeat MRI would help you manage the patient, then you can do that. So for example, you might not know if the patient's really having recurrence or not, sometimes unless you get an MRI. So it can be reasonable, especially in kids, to do that. It's kind of a bigger deal to get an MRI in kids, though. If they're really small children, they may need sedation, and that's more risk. And so you need to balance that and see, okay, am I going to get information that's really going to help me here? Yeah. And then when would a CT scan be better than an MRI for a neuroimaging study? That was answered in the webinar as well, so I'll have you refer back to the slide that answers that. So resources for learning how to interpret neuroimages. There's some websites that are dedicated to that. I know there's one called Radiopedia, and that can be really helpful for looking at examples of certain disease processes with MRIs and CT scans. So that would be a good resource. There are probably others as well, but there's really no substitute for you looking at any patient where you have ordered a neuroimaging study, or where one has been already performed and you're examining the patient for something relevant to that study. Then always review that study yourself, and there's a huge amount of learning in that. So in a patient age 40 with hypertension or diabetes, should we do an MRI if the patient has disc edema but no signs of hypertension or diabetic retinopathy? Yeah, it depends on the case. Depends on what you're suspecting. So if you suspect if it's possible the patient has a condition where an MRI would be helpful, compressive optic neuropathy or optic neuritis or venous sinus thrombosis. I mean, anything you can think of, if imaging studies may help, then yeah, you should do it. What method do you use to evaluate color vision in your presentation? To evaluate color vision, I usually use the Ishihara color plates, the pseudo-isochromatic color plates. There's a number of different other color plates out there you can use, but those are the ones that I use. Okay, and then a question in Spanish here. So in retinoblastoma, Questions about calcifications in retinoblastoma. And so yeah, that one I'll have to defer to someone else on that. I'm not as familiar with that. I don't see a lot of retinoblastoma patients in my clinic. All right. In the case of any benign ICSOL, if visual, so I'm not sure what ICSOL is, so I won't be able to answer that. What imaging features help distinguish demyelinating optic neuritis from ischemic inflammatory or infiltrative optic neuropathies? So ischemic optic neuropathy shouldn't contrast enhance, so that's going to be a big difference from optic neuritis, which should show abnormal contrast enhancement. Inflammatory optic neuropathy, that's the same thing as optic neuritis. It just may not be idiopathic, so there may be some cause for it. But if there's inflammation of the optic nerve and it's truly an inflammatory process, you'd expect abnormal contrast enhancement. You'd also expect that with infiltrative optic neuropathies. So those can sometimes be hard to distinguish just based on the imaging characteristics. Question about how do we choose between MRA and CTA? Yeah, that can be a challenge. Sometimes it depends on the availability of each in your institution. The institution where I am now, we tend to get CT angiograms. They tend to be, I think, a bit easier in terms of they're faster, give us the quality that we need, and can sometimes be less expensive than MRA as well. But yeah, either one can give you the information you need in many cases. Okay. And then a question, do you think that in all cases we can find the localization based on exam? No, you can't do that in all cases. So you do the best you can. You localize when you can, and if you can't, you do the best with what information you have. Okay, so when to scan in new onset squints in children without signs of nerve palsies? Well, it depends on your suspicion for a neurologic disorder. So if there's signs or symptoms that would make you worry about a neurologic disorder, or that would be, that makes this an atypical case of strabismus in a child, then that's when you'd want to consider imaging. Do I do a lumbar puncture on all optic neuritis patients? No, I don't. So if it's an atypical case, it's worth considering. If it's a typical case of optic neuritis, I typically do not have a lumbar puncture performed. For thyroid disease active phase, is it necessary to order MRI all the time or CT scan in some cases? You can do either one. A CT scan of the orbits can still tell you about enlargement of the extraocular muscles. And that's one of the things you're looking for with active thyroid eye disease. So you can order that. Yeah, that could be a CT scan or an MRI. Either one will answer that. Are you in favor of making the diagnosis of IH without papilledema? If it helps the patient, then potentially. We know that patients without papilledema who have IIH cannot lose vision from IIH, so that's great news for them. But if it's helpful in the management of their symptoms to diagnose it, then that can be sometimes helpful for a patient to have a label to their symptoms. Okay. What is the difference between typical and atypical optic neuritis? So typical optic neuritis has a typical clinical course, which usually involves decreased central vision, decreased color vision, pain with eye movements that may be present for a few days before the onset of vision loss. And then the vision loss tends to improve over a course of weeks to months, and eventually usually recovers quite well and does not recur, at least in the short term. So those would be typical features. Atypical is anything that deviates from that. So bilateral simultaneous optic neuritis, super severe vision loss, significant optic disc edema with their optic neuritis, early recurrence of the vision loss, or like a steroid dependence to the vision loss. Those would all be atypical features that would require further evaluation. Indications for ultrasound imaging. So I didn't really go over that, but sometimes that can be used in, especially in babies and neonates, to look for different abnormalities in the brain, and actually it can be used in utero a lot as well because there's no ionizing radiation, and so that can be an indication for it. Also, ultrasound to look for optic nerve drusen can be helpful. Also, ultrasound can be a quick way to look for even extraocular muscle enlargement or optic nerve sheath fluid that's excessive. There's a number of different things ultrasound can be good for. So certainly an option if you don't have other imaging modalities available. And then would you consider a plain CT scan with orbital cuts enough to assess cranial pathology for pediatric patients with verticaltropia? Depends on the pathology you're looking for. So if the pathology is something that could be missed by that, then maybe not. So yeah, it's hard to give a blanket statement without a specific case. I know I see cases, for example, where something like that wouldn't be caught on a CT scan. So something like a cranial nerve schwannoma. Those aren't super common in the pediatric realm, but there may be other things that can be very subtle and might not be picked up by a CT scan. So it depends on the clinical history and the actual patient. Okay, so for a case of Webino, so wall-eyed bilateral intranuclear ophthalmoplegia, the preferred imaging. So preferred imaging is going to be an MRI of the brain with contrast. That would be the preferred imaging study there. Young patient with a motor vehicle accident 6 months ago, now presented with persistent diplopia. Examination shows a sixth nerve palsy. What could be the cause and possible lesion localization? So a sixth nerve palsy can be falsely localizing. So it may not be a lesion actually along the sixth nerve. So you have to be concerned about, could there be high intracranial pressure? So you want to think about that. And then also, was there any lesion along the course of the sixth nerve? But with a head trauma, it could be a traumatic sixth nerve palsy. And in that case, it would be the peripheral nerve itself that was damaged. So for orbital cellulitis, CT scan or MRI scan of the orbits can look for orbital cellulitis. Prompt imaging modality for optic neuritis. Best imaging modality is going to be MRI of the orbits to confirm the optic neuritis. If someone is having acute optic neuritis, I also get an MRI of the brain at the same time to screen for multiple sclerosis. A case of bitemporal inferior quadrant myopia with normal MRI with contrast. What to order more? So if it's bitemporal, you want to think about localization at the chiasm. And so the next step would be to first review the MRI images yourself that was already done. And if that still doesn't show an abnormality, then get an MRI of the sella with contrast and see if that shows an abnormality. OCT can be helpful as well to confirm is there optic nerve damage, especially as there nasal ganglion cell loss, which could also localize to the chiasm. So how to write requisition for lesions involving the course of the facial nerve. You can just say which facial nerve you're suspecting the abnormality is in, and please thoroughly image the course of the left facial nerve. You could say something like that, and that would be enough for the radiologist to understand. When ordering a CT scan for an orbital tumor, in the case thinking of bone erosion and malignant tumor, yeah. So if there's a concern for bone erosion, a CT scan is probably going to be the best modality for looking for that. So yeah, that would be good to do. Is FLAIR the same as T2? So FLAIR is often a T2-based sequence, so it's not the same as T2. The difference is that T2 FLAIR has the CSF subtracted out, and the T2 does not. And so there can be various advantages to each of those. So those are a little bit different. So use of steroids and optic neuritis is a kind of outside the scope of our discussion here today. And so a question about someone who had bilateral disc edema due to oral tetracycline, and MRV showed a hypoplastic transverse sinus. And so yeah, as a hypoplastic transverse sinus is not abnormal, so there wouldn't be a need for any intervention or further evaluation of that. You'd want to treat the disc edema, and if they have high intracranial pressure, then you'd treat them as such. So a question about spinal MRI in cases of bilateral optic neuropathy, such as in the case you presented. So yeah, if you suspect or you're looking for evidence of multiple sclerosis in someone with optic neuritis, then yeah, it may be helpful to do a spinal MRI. I don't do it on everyone just because that's a lot of resource utilization. Then I'm getting MRI brain, orbits, and like cervical and thoracic spine. And certainly if they have any findings on their examination that could point to spinal cord pathology, or if there's anything in their history that could suggest they may have had an abnormality in the past related to the cervical or thoracic spine, then I would often do it. Or if I get MRI of the brain and they are close to meeting the diagnostic criteria for MS, but not quite. And if there was a lesion in the cervical or thoracic spine, then they would meet the criteria. That would be another situation where I would get a spinal MRI. In patients with convincing neuro-ophthalmic syndrome, but a reported normal MRI, what is your systematic approach to deciding whether the problem is the imaging modality, the imaging protocol, or interpretation of the diagnosis itself? So that was kind of what the whole webinar was about. So I'd encourage you to go back through the recording and remember to focus on history and examination, localization, getting the right imaging study or reviewing the localized area in the imaging study that was already done, and then review the images yourself. And you may even call up the radiologist and explain the localization too. And sometimes that you can review it together. So question about book for neuroradiology. Actually, I'm not sure. I haven't looked too much into books on neuroradiology. There probably are some good ones out there, but I'm not sure what those would be. Okay. Sorry, my Q&A is scrolling here without me. I'm trying to catch up here. So okay, so is it correct to say anechoria worse in the dark is sympathetic and in the light is parasympathetic? Not always, because not all cases of anechoria are from a neurologic cause. So if it is from a neurologic cause, then you're correct. Disadvantages of MRI. Disadvantages would be the cost, sometimes finding incidental findings, sometimes patients not able to tolerate the duration of the scan and being claustrophobic in a small space. So those would be some potential disadvantages of MRI. MRI signs of retrobulbar inflammation and pseudotumor. You'll find abnormal contrast enhancement in the orbit, so that'll be one of the main signs. Okay, diabetic patient with massive renal impairment comes with signs and symptoms of a neurologic deficit, like a cranial nerve palsy. Should they go for CTA or MRA? Maybe, it depends on what cranial nerve palsy. So cranial nerve palsy 3, if there's that and it's acute, that should always prompt CTA or MRA, particularly if it's pupil involving. So yeah, with the others, with cranial nerve 4 or 6, you might not need vascular imaging. Depends on the case. Is it mandatory to do imaging in all cases of disc edema? So all cases of bilateral optic disc edema do need imaging, and the reason for that is you have to exclude an intracranial mass lesion. So if that has not been done, that needs to be done in all cases of bilateral optic disc edema. Yeah. If you suspect NAION, then yeah, if that's you're pretty certain about that diagnosis, then you don't necessarily need neuroimaging in those cases. Okay. And can a pseudoaneurysm of the middle meningeal artery cause a partial third nerve palsy post-trauma? No, I don't see how that could happen. That artery does not travel next to the third nerve. However, if there's a CC fistula, then that can change things. There would still have to be something right next to the third cranial nerve, though. Okay, how to differentiate between red-green color blindness and okay, that's kind of a general neuro-ophthalmology question, so we'll just stick to the neuroimaging ones a bit more here. Any tips on how to learn to interpret neuroimaging scans yourself? Yeah, practice. Try to find the visual pathways, especially in patients with abnormal findings. Really make sure that you always look at the images yourself and try to see what the radiologist is telling you about. So those would probably be some of the best ways. And then use resources online well, things like Radiopedia, and there may even be some courses on neuroradiology online. So those would be things that you could try. So difference between mucormycosis and AML on an MRI, what sequence required in the for orbital involvement? So mucormycosis, so MRI is helpful for the soft tissue part of it. Mucor often invades bone too and can erode through bony sinuses. So a CT scan of the sinuses or of the head can sometimes be helpful in clarifying that part of it. And then mucor tends to progress, especially without treatment, very quickly, like over several days. And so anyone with risk factors, that should make you think about mucor, especially with that time course. How do you decide a patient needs more imaging versus better imaging versus reconsideration of the clinical diagnosis? Yeah, that's one of the magic mysteries of the universe. That's tough. You got to again go back to the basics: history and exam, localization, get the right study of the right area, and review it yourself. Those things. That's the approach that I use. Sometimes radiologists suggest further studies. How do you approach that? Well, if it's something that's relevant for me to do, then I will sometimes do those studies, depending on whether I think they're helpful or not. And then if it's something outside of my purview, then I would suggest the patient's primary care provider determine whether further imaging is necessary if recommended by the radiologist. For a roof or orbital floor fracture, what sequence? So that's going to be a CT scan, usually of the orbits, would probably be the best way to look at orbital fractures. If you could standardize one MRI protocol for every patient with unexplained optic neuropathy, what sequences would be mandatory and why? So MRI, really Orbit's protocol is going to have all the relevant sequences there typically. So we don't really have to specify the sequences. They come with it. So it's going to include T1 with fat suppression. It's going to include T2 sequences. There should be plenty of coronal images there as well to look through. So those are going to be some of the basic ones, but yeah, that's done automatically. Do I do an MRI for every case of acute cranial nerve palsy? If it's cranial nerves 3, 4, or 6, that would be ideal. If you don't have the resources to do that, then you could try to restrict it to patients where they have vascular, or they don't have vascular risk factors, or it's progressive, or there's some other unusual feature to it. Certainly, though, a pupil involving third nerve palsy that's acute that's urgent emergent neuroimaging that's needed, especially with the CTA or MRA to exclude aneurysm. Preferred neuroimaging sequence for cases of suspected NAION. So I don't do imaging for NAION. Okay, we'll answer just a couple more questions here. And let's see, I think we're almost through them all. To check for optic nerve compression and thyroid eye disease, is CT and you could do either. I think the clinical exam is going to be even more important. Is there optic neuropathy or not on the clinical exam? That should tell you. What radiological sign is more specific for increased ICP? It's distal transverse sinus stenosis. MRI signs of retrobulbar inflammatory pseudotumor. It's going to be contrast enhancement of the orbital fat or extraocular muscles or both. When clinical localization and neuroimaging disagree, which do you trust first? Clinical localization. And what systematic approach do you use to resolve the discrepancy? Great question. I have to look and see what are the absolute truths that I can rely on, and sometimes I have to revise my own diagnosis because sometimes I'm the one that's wrong. So I need to be open to that possibility. Do we need MRI of the brain in all patients with NF1? Well, it depends. If you need to look for an optic pathway glioma for some reason, if there's signs of optic neuropathy or so forth, then it may be necessary. So flare and stir specifically for T2, not T1 sequence. I think there can be a T1 flare. That's beyond the purposes of our discussion here today. But the sequences that I showed that were flare and stir, those were T2 based. Would you image for NION? If I really think that's the diagnosis, no. Why don't you use Orbit's dual echo sequence? So I don't know what that sequence is, so I'll have to defer that question. Patients with bilateral disc edema, MRI showing optic nerve enhancement up to the chiasm. Can we see any features on MRI to rule out infections like TB or lumbar puncture is compulsory? You can't really rule out TB with a scan. You can suspect it. You can't even rule it in either. You can screen for signs of it. There may be abnormal contrast enhancement of the basal meninges. That would be a sign of tuberculosis. But yeah, you can't rule it out with an MRI scan. So if you suspect it, you have to test for it, and if LP is necessary, then you'll have to do that. If you suspect that a person has diabetes or hypertension, should they undergo lab tests first or should they have an MRI? Just having diabetes or hypertension is not an indication for an MRI. All right. Well, that's a lot of questions, everybody. Thank you very much for all your participation and for the interest. And hopefully you found the principles here today useful. And we wish you the best in evaluation of your patients. Thank you.